Hello, everybody. Thank you for watching this presentation on the combination of histotripsy and oncolytic viruses for the treatment of pancreatic tumors. Pancreatic ductal adenocarcinoma is a disease with dismal prognosis and survival rates of less than 1%, 5-year survival rates, that is. Pancreatic cancers are low on neoantigens and have a dense fibrotic stroma that regulates cancer initiation, progression, metastasis, and resistance to treatments. There are no treatment options for patients with advanced pancreatic cancer, and antibody immunotherapy has also failed. Oncolytic viruses provide a form of immunotherapy. These viruses internalize into the cells by endocytosis or by binding to cell membrane receptors. There, they hijack the cell's machineries, effectively shutting the cells down. Cell lysis may be accompanied by the release of signals associated with immunogenic cell death. Reovirus is an oncolytic virus that can infect and lyse tumors. It is being developed as a systemically administered agent, which has shown promising clinical activity in pancreatic cancer patients. However, a need has been flagged up to increase the reovirus infection rates of the pancreatic tumors. So in this study, what we're asking is whether histotripsy can increase the infection rates of the pancreatic tumors by reovirus. In our experiments, murine pancreatic KPC tumors were grown orthotopically in the pancreas of subjects. These tumors were exposed to a series of peak negative pressures using the Alpinion VIFU 2000 system. Cavitation was detected, and subjects were injected intravenously with reovirus. Reovirus signal was assessed histologically, and we are also investigating the induction of the immune system. Initially, a series of tests were made to determine the induction of cavitation in the pancreatic tumors treated with different peak negative pressures of therapeutic ultrasound. A peak negative pressure of 17 megapascal was chosen because of the significant levels of broadband emissions that were seen. And in addition, ultrasound imaging of treated tumors with these peak negative pressures of 17 megapascal and duty cycle of 1%, pulse repetition frequency of 1 Hz for 15 seconds showed hyperechoic signals coming out of the tumors. Before combining histotripsy with oncolytic viruses, the penetration of Evans blue dye in the histotripsy treated tumors was investigated. Evans blue can be seen as a blue signal by visual inspection. No significant blue signal was seen in sham-exposed tumors in the absence or presence of the injected Evans blue dye. In contrast, significant traces of the blue dye were seen in the pancreatic tumors after injection of Evans blue dye in the histotripsy treated pancreatic tumors. Experiments were repeated using reovirus instead of Evans blue. No reovirus was seen in sham-exposed tumors not injected with reovirus, and no significant levels of reovirus were seen in sham-exposed tumors injected with reovirus. Reovirus is shown in these pictures in red signal. When reovirus injected animals were also treated with histotripsy, an increase in the histological reovirus signal was seen. No reovirus signal was seen in histotripsy only treated tumors, not injected with reovirus. Immune analysis of tumors exposed to histotripsy and in the presence or absence of reovirus is underway. We use single-cell analysis with APSIC antibodies to increase the depth of the analysis, and we will publish the results as they become available. As a conclusion, histotripsy increases the infection of pancreatic tumors with reovirus. We are currently processing acute and long-term immune data to determine the nature of the immune response. I would like to thank you for listening to this presentation, and I hope you enjoy the rest of the annual meeting. Thank you.